The next speaker, uh, proning in ICU is a standard of care even before COVID pandemic. But ECMO has had a new revival during the pandemic. The number of ECMO machines and centers have gone up by about 10 times in India. And refractory hypoxemia is something we face every day in our ICU. So, Dr. Jumana, Yusuf, I know her very well. She's very enthusiastic about hypoxic respiratory failure, ECMO. She's presently a consultant in HN Reliance in Mumbai. Over to you, Dr. Jumana.
Good morning. Thank you so much for inviting me back to my favorite city in the world, Namma, Bengaluru. These proning and ECMO are both topics I'm extremely passionate about, as well as a strong believer that we must try all forms of conventional therapy before we reach ECLS. So currently I'm consultant cardiac critical care and head the mechanical circulatory support program at Sir H.N. Reliance Hospital for the heart-lung transplant team. Going quickly to our topic, the respiratory system, I believe, consists of the chest wall, which the power of the respiratory system comes from the volume elastance and the flow and resistance of the lungs and the pathophysiology of ARDS is where the diffuse alveolar damage causing increased physiological dead space, lung capillary damage leading to impaired gas exchange and VQ mismatch, inflammation and edema leading to decreased lung compliance, hypoxic pulmonary vasoconstriction leading to pulmonary hypertension. In a normal lung, a patient is able to improve the respiration post-exercise by increasing, if the elastance and resistance of the respiratory system is normal. But in an ARDS lung, the elastance is lost due to edema and resistance due to hyperactivity and inflammation, both of which, coupled with muscle exhaustion, lead to a vicious cycle of greater oxygen consumption and carbon dioxide production. Adding to the pathophysiology of ARDS is the ventilator-induced lung injury, which can be caused by volutrauma, athletic trauma, barotrauma, biotrauma, and high oxygen demand due to absorptive atelectasis. So a lot of efforts have been made to improve mechanical ventilation so that the mechanisms of mechanical intervention so that we do not cause ventilator-induced lung injury and going with the zones of the lung which are exposed to extensive transpulmonary pressure with consequent tidal overdistension and increased dead space. The different modalities would be low tidal volume to reduce the low volutrauma and athletic trauma, prone positioning for reduction of volutrauma. So prone positioning has effects on all the aspects of the lung protection, and if all else fails, especially if the ventilator-induced lung injury is then potentially decreasing the cardiac output due to hypoxic pulmonary vasoconstriction, then ECLS is the way out. So the compliance of the chest wall anteriorly is better than posteriorly. So when we place the patient in prone position, more often than not, actually the compliance may not improve. So what we are depending on is the lung compliance, and that tends to improve because what has been noticed is that the transpulmonary pressure works in such a way that the opening of newer gas exchanging units uniformly across the lung once the patient is in prone position. Also, the volume of distribution in prone position of the aerated units is better, while the perfusion doesn't change much. So the recruitability is better. So a simple change in plateau pressure, improvement in plateau pressure or improvement in tidal volume tells you that whether the patient is benefiting from prone position. So what the effects of prone positioning would be expected to be improved oxygenation due to quantity of lung available for gas exchange, homogeneity of inflation, and distribution of the tidal volume moves towards the posterior and para-abdominal regions where the supine ventilation is usually absent. So your oxygenation improves. There is an improvement in carbon dioxide clearance which indicates recruitment and decreased dead space, and carbon dioxide improvement in carbon dioxide clearance is a very good indicator that the patient is benefiting from prone positioning. And finally, the hemodynamics. The APRONET study actually did not include patients with less than MAP less than 65 versus the ProSeva study, which included patients even though they were on a certain amount of vasopressors at a rate not different from the conventional group, and their survival in prone position was 72%. So this study by Josviak et al. Reported that the cardiac index did not change. In fact, it improved with prolonged proning because of right ventricular unloading, which helped to normalization of right ventricular function in patients who initially had systolic right ventricular systolic overload or cor pulmonale. So quickly, the ProSeva study, which was the largest prospective study with 466 subjects, which had included patients at PF ratio of 150 on FiO2 of 0.5 and PEEP of 6 centimeter of water. They found that subjects randomized within 33 hours of intubation and an average of 17 hours per day of proning had definite mortality benefit at 28 days and 90 days. And both ventilator-free days were also improved in the prone position group. The contraindications would be unstable patients, unstable pelvic or spine fractures, morbidly obese patients, pathological abdominal surgery or within 24 hours of tracheostomy, and second and third trimester pregnancy. Many of these patients then become candidates for extracorporeal life support because they cannot be prone for recruitability. The side effects, of course, being pressure sores, hemodynamic instability, loss of lines, accidental extubation, tube blocking, facial edema, worsening hypoxia, and arrhythmias. I'm just running through the proning part because I think there's nobody in the audience who doubts their benefits. But safe proning, of course, you have the pre-move checklist and the post-move checklist, and all hands on board, right from the head end to the toe end, watching the patient while we prone. So coming to extracorporeal membrane oxygenation, with this ECMO coming on this scene, a lot of intensive care has finally got respite from when they're up against the wall where conventional treatment is concerned. We do excellent conventional treatment, but there is a point where we just know that a patient is not going to make it without something extra, and that's where ECMO comes in. I am not a believer of awake ECMO, as in you put the patient on ECMO first. You must try conventional, but it is not a bad option to go for an early or timely ECMO. It's the same as a cardiopulmonary bypass managed in ICU for management of acute circulatory or gas exchange failure, and should be offered if conventional treatment fails to resuscitate the patient. The principle is very simple. You don't worry about what the lung is doing. You take over the gas exchange and even the hemodynamics if required to achieve the functions of the heart as well as the lung, and to prevent further deterioration of the vital organs like kidneys, liver, and brain. The ideal would be a physiologically young patient. I say physiologically young because there's no age cutoff as such, so long as the patient has had a fairly normal quality of life before we go on to ECMO, and it should be an acute, reversible, single or dual organ failure. I say dual organ, by which I mean a heart lung. When your kidneys start getting involved, it's probably a window to go on ECMO first rather than CRRT, when you know that the primary issue is in the heart or lung. So the components of ECMO are very simple. It's a centrifugal pump which works on a flow pressure mechanism, a membrane oxygenator, which is your gas exchange unit made of polymethyl propylene. It also gives temperature control to the blood that comes out. So, and you have the cannulas for initiating ECMO. The cannulation strategy determines whether you're going to give heart-lung support or just lung support. And if you're doing a heart-lung support, you go from a peripheral vein, like the femoral vein, and return to a peripheral artery. That's the simplest form of a peripheral veno-arterial ECMO for combined heart and lung support. And a venous ECMO, where you take from a peripheral vein and return to the internal jugular vein. This is the simplest form of a peripheral venous ECMO. So actually, venous ECMO, veno-arterial ECMO is more like lung, not heart or lung support. It's more like gas exchange failure versus circulatory failure. So when you're looking at gas exchange failure, you are looking at an inability to maintain an SaO2 less than 88 or a pH of more than 7.2 because of respiratory acidosis. When you have reached mechanical ventilation settings which are harmful, that is a plateau pressure of 35 and a tidal volume almost touching 6 ml per kg, and you have tried diuretic therapy, high PEEP, as well as recruitment maneuvers such as proning and paralysis. The Murray score, which guides us as to the window when we should, to quantify when we should go for extracorporeal, takes into account the chest X-ray involvement in terms of quadrants with consolidation, hypoxemia in terms of PF ratio, PEEP, and compliance. A PF ratio, a Murray score less than more than 2.5 would be an indication for ECMO. So ARDS related mortality during mechanical ventilation is due to hypoxemia, hypercapnia, and high volume, high pressure ventilation, which all lead to RV failure as well as tissue hypoxia and ventilator associated lung injury, again leading to multi-organ disorder and death. In ECMO, you can improve the outcomes by oxygenation, carbon dioxide removal, and ultraprotective lung ventilation, which all improve the RV function, avoid hypoxia, avoid ventilator-associated lung injury, and better survival. What method to use? If it's refractory hypercapnia, you go without hypoxemia. You use a low-flow venous ECMO or minimally invasive ECOR. If it is with hypoxemia, you do a ultra-lung protective mechanical ventilation or a along with low-flow ventilation venous ECMO or minimally invasive ECOR, or you go for a venous ECMO. This should be without distributive shock. If with distributive shock, you will have to do a veno-arterial or a veno-arterial venous ECMO. When to initiate ECMO, also ECMONet, Caesar, Eolia all had slightly different cutoffs. The mortality risk more than 80% was constant. Murray score or PF ratio was what they used, less than 80, less than 70, or pH. The Eolia trial, which the primary outcomes were not significant, actually used a PF ratio which was really low. It was very much a rescue lung mechanism, and the secondary outcomes were better, where they went from mechanical ventilation in the correct window. So when considering ECMO in India, we must go in the second category, that is consideration for ECMO, where the mortality risk should be around 50% and not more than 80%. The PF ratio has just gone less than 150 because the logistics to arrange as well as the decisions to be taken are quite difficult. And if the patient is to be transferred to an ECMO center, early decision is better for better survival. So what is the difference between the native lung and the ECMO lung? The problem is that we need to understand this when looking at what the ECMO can achieve for you. So our native lung has a surface area which is 150 meter wide, while the ECMO lung is only lower than 4 meter wide. And the interface between the blood gas is only 1 to 3 micrometers in our native lung, which is 10 to 30 micrometers thick in a ECMO lung. The surface area that the blood is exposed to again is only 1/10 in the ECMO lung. So the delivery capacity is only 250 to 200 ml per minute, which can be obtained with an artificial lung. So you are resorting to ECMO when your native lung is unable to achieve this much. So when you are on ECMO, again, the expectations should be of permissive hypoxia and hypercapnia. What you can achieve though is you can wake up and start rehabilitating this patient and go to rest settings on the ventilator so that you are not at least worsening the ventilator associated lung injury while the lung gets a chance to improve. The different membrane surfaces decide. So there is something I call as a rated flow, and that is how much the oxygenator can achieve. There are only 3 settings for ECMO: the blood flow, the sweep gas flow, and the ECMO FiO2, which will help us to improve the oxygenation. And the other thing that helps to improve the oxygenation is your cannulation strategy and correct placements of the cannula. The blood flow rate should be at least 60% of the patient's cardiac output. So, and you must work on decreasing the demand, that is decreasing the temperature, stress, sepsis and thyroid state, improving the thyroid status, while you depend on the blood flow rate, sweep gas flow, and to a lesser extent to the ventilator. Actually, I never depend on the ventilator FiO2 on ECMO for improving your oxygenation. What is important here is that you must have realistic expectations. And when a patient is in sepsis, you will have lesser flow going through the oxygenator, so you will require higher flows. Now, proning on ECMO, if you are not meeting ECMO goals on ECMO, oxygenation goals on ECMO, do you prone? There are a few studies on that. Some found that oxygenation all found that oxygenation improved, but whether it was sustained, some of them were responders, but some were non-responders. The static compliance plus the optimal PEEP was improved, but the largest study by Gianni and all showed that they found lower mortality but longer duration of ECMO in the prone group. Safe proning again requires a lot of hands. I prefer to have the person the ECMO specialist at the head end and a perfusionist at the leg end to troubleshoot, and at least 6 hands on board for proning these patients. But personally, I feel that the problems with proning on ECMO is that you are having to sedate and paralyze these patients. You can achieve similar or better rehabilitation and lung functions if you can wake up the patient and get them to rehabilitate actively with improved delivery of the engagement in spirometry, facilitation of patient communication and decision making, and better nutrition. Again, it improves the better tone of respiratory muscles and diaphragms, which improves the FRC and decreases the ventilation perfusion mismatch and decreases VAP. I think the clincher here is doing an early tracheostomy post putting on ECMO and then just waking up and rehabilitating the patient. There may be instances of high work of breathing, especially if the patient is in pulmonary edema, and there is a risk of pulmonary pressure being high, leading to spontaneous induced lung injury. But more often than not, I have found that awake ECMO does help. So I would like to leave you with this message that ECMO should be done in the correct window, and want to reinforce the belief that once the patient is on ECMO, the sky is the limit on how much you can rehabilitate while you wait for the patient to recover. Thank you.